So please start.
Good evening, everyone. This is 35th Webisode, 35th fifth episode of our online teaching program. And thank you for being us within this journey. We are enjoying and we hope that everyone is learning and it's helping them with their day-to-day clinical practice, mainly students, and their exams, and it will help them in the future practice. So today we are going to discuss pancreatic cystic neoplasms. And we all know that the incidence of pancreatic, not exactly incidence, the pickup of pancreatic cystic neoplasm is increasing with the increasing advent of imaging and routine investigations, especially health checkups. And many of these patients doesn't require an intervention, but uh, diligent workup and then management is the key. So today we have Dr. H. Ramesh. Dr. H. Ramesh doesn't need introduction in GI community. And we also have Dr. Soumil Vyas, Dr. Nikhil Gupta, Dr. Saurabh Galodha, Dr. Ruchi Rastogi, and Dr. Sawan Bopana. So Dr. Soumil Vyas is at Mumbai, HN Reliance Foundation Hospital. Dr. Saurabh Galodha is from AIIMS. Dr. Sawan Bopana is our dear colleague. He will be the gastroenterology side, so he'll be telling us about endoscopic ultrasound, specifically for pancreatic cyst. And we have Dr. Ruchi Rastogi, who's a radiologist, and she specializes in HPB radiology. And Dr. Nikhil Gupta is a GI surgeon at Action Cancer Hospital, New Delhi. So with this, I would request Dr. H. Ramesh to, sir, ready?
Yes, sir.
Your screen, sir. Right, you can see that, sir.
So, good evening, and thanks to Nikhil for inviting me to join this, obviously a very vibrant educational and process, and one hopes to be educated at the end of it substantially. So my task is just to provide a little overview as a sort of starting point for the very interesting case discussions that are to follow. And let me start right by asking a few questions. What are the cystic lesions that we are talking about? And this is a list. You have to group them into 5. You must remember that pseudocysts are definitely part of this equation, that they are not pseudocysts unless they are proven to be. They may mimic cystic neoplasms. And there's the serous neoplasms, the mucinous neoplasms, of which intraductal papillary mucinous neoplasm is just one side, the 2 sides of the coin, MCN and IPMN. Then there is an interesting entity of cystic variants of solid neoplasms, and that's something that you must keep your eye peeled for, because even ductal adenocarcinoma can present with a cyst, as a cyst. And of course, the SPEN, which is very common in our country, and the lymphoepithelial cysts. The clinical settings can be just incidental, and over 50% or even larger, depending on the type of patients and type of practice that you have, may be incidental. Symptoms may be alarm symptoms, pain, weight loss, jaundice, and they usually get the attention they deserve. The inflammatory symptoms, when they are present, they may often suggest that it is a pseudocyst, but you know that MCNs can also produce inflammation around them. The biggest group, even in the symptomatic group, are those with non-specific symptoms, unfortunately. And because of the increase in imaging, as Nikhil said, 1% of all CT scans done in the hospital will show some cystic lesion. So they are victims of medical imaging technology. They're usually, the incidental ones are smaller, older patients. They are, of course, less likely to be pseudocysts. There is a certain number that may be malignant, but there's usually larger sizes which are likely to be so. The question always is that whether you can have imaging identify each and every type reliably, benign from malignant. The answer is yes, and the answer is no. You have multiple, you have these four. This is a very classy picture which has been around for the last 20 years. If you have a unilocular cyst, you could have a pseudocyst, you could have a unilocular serous cystadenoma, a mucinous cystadenoma, even an IPMN or a lymph node. If you have this with the central scar, you're dealing with a serous cystadenoma, a mucinous cystadenoma, which is a macrocyst. And if you have solid components, it's very likely to be that there is tumor. And yet another picture showing you the typical serous cystadenoma, the mucinous cystadenoma, the branched duct grape-like IPMN in the uncinate process, and the main duct IPMN with dilatation of the duct. So these are the canvas of imaging, but unfortunately, CT-MR is unable to really distinguish these lesions, especially when they are small. MR is more useful because it has no radiation, and these may be required to be, surveyed periodically. If you had to really study all the literature, by and large, CT is equal to MR is equal to US, with MR being marginally ahead. But then when you put in a needle into the cyst, then you have advantages. But then you have to balance it with the small risk of complications. So you need to be sure whom you use it for. Another close-up picture of a serous cystadenoma, the central scar, and the typical appearance of the section. This tumor became so large, the patient insisted in having it removed, and only those patients required surgery. Unfortunately, EUS alone may not resolve the issue, and the kappa value of agreement among different endoscopists is also less. Therefore, FNA and aspiration may be required. If you have a high CEA in the fluid, or if you have a high CA 72.4 in the fluid, then we are dealing with either IPMN or MCN. But if all these are consistently low, except the amylase, which is high, then it could be a pseudocyst or a serous cystadenoma. Size does matter. First of all, very small cysts are difficult to characterize. They may often be benign, and if they may often be serous cystadenomas, but large tumors are more likely to be sinister. And in fact, in this large series published a decade and a half ago from the MSKCC in New York, about 540 patients, small lesions were generally asymptomatic, and they were able to be followed up, whereas the recommendation was you should resect all lesions above 3 centimeters and those with cystic components. And that's also a criterion for how frequently you would do surveillance on these patients as to whether the lesion were large or small under the 3 centimeter mark. What about the smaller ones? I have a problem because this paper, again from the Mass General Hospital in Boston, suggests that 20% of cases in the small group, cysts smaller than 3, had borderline or in situ malignancy. So it is a concern that on the one side, you shouldn't be doing surgery unnecessarily. In the other, you have to be aware that they may have malignancy lurking somewhere. If they have, of course, double negatives, negative cytopathology, as well as normal CA99, it's pretty much safe, but even that's not completely safe. The issue is also the comorbid illnesses, the age of the patient, the symptomatology. And it's very easy to understand that if you have a 3 centimeter cyst at the age of 65 with no comorbid illnesses, a large number of these head lesions may actually be subjected to a Whipple resection. However, if you see the same group at 85, the number straight to Whipples is absolutely 0. Do nothing is the big group. And so other factors also must be taken into consideration. But by following up these patients, they haven't really lost cases because of, say, inoperable malignancy. And that is the lesson. So you must balance the risk of missing the high-risk lesions and the risk of surgery in low-risk lesions. And this is an example of a mucinous cystadenoma with the septae here and the cut specimen. I don't know whether I should go through each one of these because that may not be conducive to the panel discussion that's going to follow. But some new trends that this is a multi-institutional validation study done and published only a few months ago in the Annals of Surgery, which showed that if you did a combination of CA72-4, matrix metallopeptidase 9, and soluble Fas ligand, and those things are available now. If you just have to set up the laboratories, you can actually have a very high chance of picking up the bad ones. By and large, serous adenomas must be followed up in a non-operative manner. And if surgery is done, it should be a parenchyma conserving pancreatectomy. It's a little different from mucinous cystadenomas because there is a high risk of malignant transformation of up to 40%. So many of these patients, most of these patients may end up requiring surgery. And in that case, it may well be a distal pancreatectomy with lymph node dissection with or without splenectomy. And we need to do a curative resection. It's very important that if you have lymph node involvement, the survival is very much lower, especially if malignant transformation has happened. So this is why mucinous cystadenomas perhaps are best treated, fairly energetically rather than to sit on them for a long period. So if you have lymph node positive disease, you have a 16-month survival, whereas it's 81 months in the lymph node negative patients. IPMN is not so common in India, but it's certainly not uncommon. And this is a typical patient of a main duct IPMN on the right and the branch duct IPMN in the uncinate process on the left. And the main concern is the high frequency of high-grade dysplasia and invasive carcinoma. And if you resect the patients in time, you have a good survival rate. I'm just going to step up and forget some of these slides because these are not necessary. The aim in surgery of IPMN straight away becomes achieving margin negative resection, also looking for, carefully at the imaging to look for, a second lesion, looking at multiple multicentric lesions. Multicentric lesions straight away become candidates for a total pancreatectomy. But even if you do a Whipple resection, which is the most common operation, you would then have to do margin frozen sections and then determine that there is no disease in the pancreatic margin in order to proceed. If there is a low-grade dysplasia, by and large, you do not resect further. But if you have high-grade dysplasia or cancer, or if you have exuberant papillary nodules at the resected margin, then you need to resect further. And that's really caused an expansion in the role of total pancreatectomy for IPMN, which has really gone up from before 2000 and in the past, in the post-2006 era. This is an example of a 45-year-old lady who had presented with biliary obstruction and head mass and classical features of IPMN. This was a resected specimen. If you notice, there's a cut here. The patient actually underwent a distal pancreatectomy. A Whipple resection, and then it was clear that the body and tail were badly affected, and therefore completion pancreatectomy with splenectomy was done. Patient is still alive 14 years after surgery. So this is a famous Fukuoka guideline which is published in IPMN, the Japanese being pioneers and leaders in teaching us how to manage these patients. So if you had high-risk stigmata of malignancy with obstructive jaundice and an enhancing solid component within the cyst, it's a no-brainer that you need resection, and there is no further, requirement for evaluation. And if there are worrisome features, then of course you do endoscopic ultrasound. And then if you find mural nodules or you find suspicious lesions, then you can consider surgery again. But if you do not find those, then follow-up is the answer. Bile duct, for branch duct, interductal papillary mucinous tumors, again, if you have mural nodules or the size which is increasing more than 5 centimeters, or if the cytology is positive for high-grade dysplasia or cancer, then you must practice some form of parenchyma conserving resection. The big concern about the IPMN is that we have so many guidelines published from the IAP, from the American College of Gastroenterology, the European and the AGA, and none of these have actually been able to match each other. There's been a lot of difference of opinion, and that's a matter of concern. SPEN is not strictly a cystic neoplasm, but it has cystic spaces, and it is classified as such. And we do see a huge number of these patients, and we unfortunately have begun to see a number of patients with malignancy who are difficult to resect and difficult to keep free of disease, and that figure is going up to 10 to 15%. And surgery, of course, is the mainstay of treatment. While we should preserve the parenchyma, but you should not do enucleation, and you should get negative margins. And if you resect a benign tumor, you will get good 5-year survival. You get long-term survival. But local recurrences do happen, and that's a major problem. So you need not just 5-year follow-up, as the slide would indicate, but you should probably follow up for life. We've had a few cystic neuroendocrine tumors. So if you had a 2-centimeter cystic lesion with even some amount of enhancement within the cyst, especially even if it's in the periphery, then the USFNA was done, and that showed neuroendocrine tumor, and then the patients were resected, and obviously it was a good decision. Indian data, a paper was published in 2019 from several centers, including ours. I think it was Tata who were the sort of focal point for this study, Shailesh and Vikram and the rest. And there was AIG, there was All India Institute of Medical Sciences, there was GEM Hospital, Amrita Institute, and of course, that's it, in Stanley Medical College in Chennai. And they suggested that of the 423 patients they reported from 7 centers with the 10-year follow-up, the commonest cystic lesion was a solid papillary epithelial neoplasm, followed by an MCN, followed by SEN, and CECT was the most common investigation done. And US was done in a shockingly low 16%. And I was surprised with the data. 66% were located in the body and tail. Either this meant that we were taking out only the really obvious ones, which didn't even require US, or and that's what the critical analysis of the data suggested. Less than 10% were malignant, and most patients underwent distal pancreatectomy. A quarter underwent a Whipple. And again, the other surprising thing was that 20% only had laparoscopic resections, despite each of these centers having a lot of laparoscopic capability. So one just has to understand that the size and the type of lesions were such that they did not merit laparoscopic. Some final words: that it's so important to have teamwork, and it's also important to have patients to be seen concurrently by different specialists instead of being seen sequentially, which is usually the bane of our healthcare system, if we need to have the answers right. And I would like to conclude by saying that we need good clinical evaluation and radiology, not just in serous cystic adenomas. If you see a cyst in the pancreas, consider the question: do we really need to intervene? If you need to intervene, are we going to intervene in a diagnostic manner using an EUS or a ERCP, a USFNA, or are you going to subject them to surgery? As the lesions get larger, or if they have worrisome features, they must be considered for surgery, which should be now definitely laparoscopic or robotic, if you wish, whenever feasible. And of course, smaller lesions should be closely followed up. Thank you very much, and I hope I haven't taken too much time and disturbed the forthcoming panel discussion, which I'm looking forward to participating in. Thank you very much.
Thank you, sir. Thank you for an overview. It was really excellent. It has set the stage, and it was like informative. So with this, I will start the panel discussion. And So can everybody see my slide?
Not yet.
I don't think I've done that. Yes. Can you see my screen?
Yes.
Okay. So thank you. And so I've already introduced the panel. So we have Dr. Ramesh, Dr. Vyas, Dr. Nikhil Gupta, Dr. Ruchi, Dr. Sawan, and Dr. Saurabh. So we have seen like how we evaluate these lesions, what are the important ones, which to operate, which to observe. But it's very complicated actually, especially distinguishing between some of these lesions becomes challenging at times. And so I'll just start with Dr. Soumil. So Dr. Soumil, what specifically you'll ask in the history when you have a patient with pancreatic cystic lesion, what exactly will you look into the history, and that will help you decide the future course of action?
I think just like any other case, a comprehensive medical and history must be taken, regardless of what the situation is. But specifically from this point of view, you basically look at a history of pancreatitis or biliary disease. I think you must ask for a history of gallstones, gallstone-related symptoms, presence of pancreatitis, whether and what happened as the patient had previous such episodes before or not. You go through a comprehensive review of their previous blood reports, particularly looking at the liver profile, transaminases, amylase, lipase, and if they have had tumor markers before. But I think a history of pancreatitis is very important because the most important differential would be a pseudocyst, and the treatment of a cystic neoplasm versus a pseudocyst is different. So that's where you need to focus on and try to make sure that you're not treating a cystic neoplasm or mistaking a pseudocyst for a cystic neoplasm or vice versa. Of course, a history of jaundice, gastroduodenal outlet obstruction, all these symptoms, which would be true for any major GI pathology, should be taken. But specifically from the cystic neoplasm point of view, you do need to make sure that the patient, you're not dealing with the patient with pancreatitis.
I guess to sum up, what you're suggesting is that history will mainly help us distinguish these lesions from pseudocyst and one.
Yes,
and
to a significant extent. Apart from the radiology, of course, which you would depend on to decide further management.
Yes, yes. So now let's talk about a case. A 50-year-old lady presented to us after a routine checkup and ultrasound showed a pancreatic lesion. So Dr. Nikhil.
Hello. Yeah.
Yeah. So like once you have ultrasound which shows some lesion in the pancreas, possibly cystic, what would you do next? Which investigation?
I think here we are talking about a patient who is totally asymptomatic without any previous history. As Dr. Soumil said, that there is no significant history, and on a routine checkup, the patient is presented to us on an ultrasound. First of all, I would like to assess the size of the lesion. Although that doesn't make much of a difference. In a 50-year-old lady with a pancreatic cystic lesion, my first impression is that I would go for a contrast enhanced CT scan with a pancreatic protocol.
Would you differ?
Yes. Anyone else?
Yes.
Why not MRI straight away?
Yes, definitely. MRI is also, as Sir said, that there is not much difference between an MRI and a CT scan. And as far as I am concerned, my ease of reading a lesion is better with a CT scan. If at all I am planning for any surgical intervention, a CT scan for me is a much better modality for planning any surgical treatment in those patients. And I'm comfortable with CT scan. That's why I go for it, because there's not much difference between a CT or an MRI.
Dr. Ruchi?
Yeah, so
would you agree with this statement?
I fully agree with Dr. Nikhil that the GI surgeons, gastroenterologists, they are very comfortable with CT scan. I'm sorry, my video is somehow not working, so I think I'm not visible on the screen. But CT scan is very easy to read and it's very comprehensible. But if you really go into the depth of MRI, even a plain MRI gives you much more information than a contrast enhanced CT scan. So if you are comfortable reading a MR image, just ordering a MRCP will give you a lot of information about the contents of the cystic lesion, septae, thick or thin septae, hemorrhage, debris, associated peripancreatic fat stranding also, and pancreatic ductal communication, bile duct, MRCP information, everything. MRI, it's not going to miss anything. And if you add contrast to MRI, then it will give you much more information than a CT scan. So that is what is a radiologist's perspective on that. But I do understand that CT is much more comfortable to order and to interpret. Yeah.
Dr. Nikhil, I was going to say that, I was going to tell Dr. Ruchi as well that the big problem is to schedule a MRI
Yes.
when a patient comes in with abdominal pain, a mild abdominal pain, and you see a lesion, and let's say he or she has come from afar, they want further evaluation. So it's very, because of the times, scan times, it's very difficult to schedule an extra MR into the day schedule. And that usually throws the patient into, complete disarray.
That's right, sir.
And then we have to go for a CT, not because the CT is more efficient, but because it's just available and it's easy to do.
That's absolutely right, sir.
So this patient also underwent some tumor markers which were normal, and she underwent a MRI, plain MRCP actually, and I'll just show you some images.
Why would anybody do a chromogranin A for the start?
It was not start, it was after the MRCP, so it just has in the slide, so that's okay. So this is the MRCP of this patient. Can you see?
Images are not really showing the main tumor.
Yeah, is it showing now? You see?
It's visible in the body, but whether it's a multicystic lesion, it's very difficult to,
Yeah, I've just stopped it there. Dr. Ruchi, can you see? Can you just describe it a bit?
Actually, what you have written above, it's not seen very well on the images. Are there some more images available?
No, these are the images which we have. Which screen are you able to see? Are you able to see the DICOM viewer, or you're seeing the?
We are seeing three screens. We are seeing three cuts of the CT.
Yeah, there is one fourth one on the extreme right of the screen, I think.
Oh, okay.
We have to minimize the
even there it is not very well visualized.
Screen sharing we have to minimize.
So in the second image on T1 weighted, the second image, we can see a heterogeneous lesion in the pancreatic body, and just a part of pancreatic tail is seen in that. The remaining pancreas is not very well seen. In the third image, I cannot see much of the pancreas.
Are you now seeing a single image? No.
No. We are just seeing the PPT image containing 4
images. The PPT, so I think it's not projecting.
Not able to see the DICOM images.
Maybe in the next slide, I guess.
No, then I mean I just have to stop and sharing. So basically, you've seen this image, Dr. Ruchi, if you remember, no?
Don't exactly.
The last one which we discussed.
Play it.
Yeah, actually, you have not played.
I think you can play it.
Yeah.
Yes, now we can see.
Yeah.
It's too fast for surgeons.
That's why I was just trying to play.
Yes, I can
stop
see
sharing
it now.
and then you can see it.
Yeah. So there is a lobulated lesion in the pancreatic body, which has multiple thin septations and locules in it. And there is no definite scar in the lesion. And the peripancreatic fat planes are absolutely fine. The remaining the pancreatic duct is mildly prominent, especially in the distal pancreatic body and tail. Yeah, and the locules are multiple. They are like more than 6 in number. The size of individual locule is less than 2 centimeters, which is usually the cutoff taken. So I think because of these imaging reasons, the differential diagnosis of a serous cystic tumor must have been kept in this case.
What is the total size of the lesion?
It must be around
3
4
centimeters.
centimeters on images, 3-4 centimeters.
So MRCP diagnosis was serous cystic tumor and query branch duct IPM. And following this, the patient underwent an endoscopic ultrasound. So,
Nikhil, if there is upstream pancreatic duct dilatation, are we justified in diagnosing serous cystinocarcinoma?
this patient doesn't have upstream pancreatic duct dilatation.
Okay.
It's just mild prominence, which could be because of mass effect also. Like, it's not significantly dilated.
Fair enough.
So next question is like, what do we do with this patient? Dr. Saurabh, what would you do now?
I guess we can do an imaging in the form of an endoscopic ultrasound. The only thing probably it will show us is that if there is really a communication between the main pancreatic duct and not, because that may change your diagnosis, as you've already mentioned the 2 differentials that you've kept. That is one. Otherwise, the size per se is less than 3 centimeters, and the patient is asymptomatic, 50-year-old lady. So to evaluate, I guess I would approach it as a next investigation, probably with a endoscopic ultrasound. That would be my
Which all patients you will send for endoscopic ultrasound. So routinely some patients, or you'll select out some patients.
So usually for an endoscopic ultrasound, the cutoff as far as the size is concerned is usually 3 centimeters and above. This is a very borderline kind of a lesion, which is close to 3 centimeters, but not exactly. And the only other thing is the MPD is prominent in this patient. So we are not sure whether there is a communication with the main pancreatic duct or not. So in this case, that is also something which makes me think in terms of some other differential also possible. Although typical appearance of a multicystic lesion at this age group, it could be a serous cystic neoplasm, which we could just observe also. But there are these 2 factors in which I would actually send the patient for an endoscopic ultrasound.
You would agree. Dr. Soumil, you have anything to add there?
Yes, I think I would offer this patient an endoscopic ultrasound after due discussion. I mean, if the patient is willing to come back and have a very close follow-up, then and is not willing for an endoscopic ultrasound, then one option would be to do a re-imaging in 3 months' time with a MR. But the ideal way forward would be an endoscopic ultrasound with sampling of the cyst fluid and send it for amylase, CEA, mucin, and check out its characteristics.
So this lady did undergo an endoscopic ultrasound, and this is the endoscopic ultrasound report. It says hypoechoic lesion with teeny anechoic areas in proximal body and neck with increased vascularity, and there were some lymph nodes also. So following this, a lot more this patient was not worked up here. I mean, this workup is being done elsewhere. We got a patient after all these things were done. So a DOTA PET was done. PET CT was done, and obviously there was no DOTA uptake and mildly FDG avid lesions. This is the CT image, and EUS finding is there. So, and Dr. Ruchi, can you just explain the CT to us?
Yeah, so on the CT image, we can see that there is enhancement in the lesion. There is enhancement, definite enhancement in the wall and in the septae. And overall, although I just have one phase, the arterial phase, I don't have the baseline non-contrast phase, but the lesion appears to be enhancing.
So, Nikhil, now what?
First of all, the imaging, I think the differential diagnosis, one of the differential would be a neuroendocrine tumor. I guess that would be given by my radiologist, considering this CT scan, because but there is no significant DOTA uptake. Still, in this lesion, I would require an EUS of this patient plus a fine needle aspiration cytology, if possible, in order to know exactly what I'm dealing with. Because I am keeping neuroendocrine tumor as one of my differential diagnoses. So for me to know the grade also is very important.
I mean, yes, looking at this scan, yes, but like when we take that MRI, which I've just shown you with that cystic lesion, would you still want to keep NET as diagnosis?
I was just concentrating on this one with the MRCP report, and considering this lesion, I think my first differential would still be either I'm dealing with a serous cystadenoma or this branch in IPM.
Yes, I mean,
Was an
like
FNAC or a biopsy done at EUS?
yeah, it will be done. So we'll have to. So this endoscopic ultrasound was done without FNAC or biopsy. So we did one because obviously now some of the differentials after this much workup we consider, and so we did an endoscopic ultrasound, repeat endoscopic ultrasound, and it said that it's a microcystic lesion. We did do FNAC. The fluid was too less for any analysis, and cytology was basically non-contributory. Dr. Sawan?
Yes, Dr. Nikhil.
So can you enumerate, like, how do you distinguish between some of the lesions on endoscopic ultrasound, and what does this like make sense to you? What you'll interpret this report as?
So basically what we're looking at on an endoscopic ultrasound, first of all, the serous cystic neoplasms have a very classical appearance. And the cyst size are like small cysts, which are continuously, almost regularly placed. And sometimes we have serous cystic neoplasms with large cysts also, and then the differentiation becomes difficult. But as I remember in this case, the cysts were all equally equal and regular and thin-walled, and all of them were very small in size. And there were no solid areas in. We also looked for any solid areas within the lesion, and because it's a purely cystic lesion, and that goes more in favor of a serous cystic neoplasm. So in this case, as I remember, there were no real solid areas, and also there's some amount of post-acoustic enhancement. Basically, when the ultrasound waves pass through it, there is a little enhancement behind the lesion, and that was there in this case. And as mentioned, we also look for duct communication. So one of the important things that US helps is to clearly look at whether there's any communication between the duct, and therefore differentiated from a branch duct IPML. So there was no real duct communication, and there was no real cutoff of the main pancreatic duct. Also, the main pancreatic duct could be continuously traced from the tail up to the head of the pancreas. So there was no real reason of worry with the upstream pancreatic duct dilatation that was described. One odd thing about the lesion was that on Doppler it showed areas of vascularity. So now that was something which actually we looked at it for a long time, and so that's where we thought it could again be an unusual NET with some areas of necrosis, considering the CT report also. So we wanted to do a contrast enhanced ultrasound on this, but SonoView has become very sparse and not really available right now because of some import problems. So we really couldn't do a contrast enhanced ultrasound. So probably a contrast enhanced ultrasound could have helped differentiate whether this is a NET with areas of necrosis or a serous cystic neoplasm, because then NET would generally show an uptake of SonoView. But all in all, looking at this lesion, there were no real areas of solid. So there were no solid areas, and there were only small microcysts and the classical appearance of a serous cystic neoplasm. The other thing is the material also. So if it's kind of an NET, there is some amount of material that we can aspirate, not only just fluid. So in this case, as we've seen that we couldn't really get out any fluid, a lot of fluid. We did needle the lesion, but there was not much of fluid that could come out. The cysts were very small, and neither there was any material that we could aspirate. So that's something I think.
one issue. What about those lymph nodes? Did we target those lymph nodes? There were many lymph nodes in and around the lesion, like in the peripancreatic or the hilar and perihilar.
No, we did not target them. I think they were not really more than 1 centimeter.
Okay.
Imaging doesn't actually show many lymph nodes. The previous
But
US
the
report
US
did.
report showed, yeah.
Yeah, it did show, but then I mean, it wasn't very suggestive. The imaging we had a DOTA, we had and one
Actually,
MRCP.
there is one discrepancy in this case. The contrast is available on CT, in which we do not have a baseline non-contrast image, and the MR in which we have baseline non-contrast does not have a contrast. So the enhancing lesions which were seen on CT ideally should have been compared with the non-contrast, whether it was really a debris or it was enhancement. How much?
Yeah, Dr. Ruchi, means it was
Yeah.
enhancing. I mean, we have, like, for the sake of space, I didn't put all the images here, but like it was enhancing. Those some of the peripheral septas were enhancing. We did compare it with the non-contrast images. So, Dr. Sawan, the question which I would want to ask you here, like Dr. H. Ramesh also pointed out, that there is a lot of lack of kappa. I mean, there is a lot of inter-observer disagreement when we talk about US. So how confident would you be, and would you want your patient and surgeon to be when you say that this is a serous lesion or a mucinous lesion? What do you think?
So either the inter-observer agreement is very good for lesions which are classical. For example, if you see a serotech, the two of us were doing this, Dr. Vyas and myself. So both of us, without knowing the CT report, would definitely have no this thing in calling it a serous cystic lesion, serous cystic neoplasm. So now when there was a report with the enhancement and when there was vascularity, of course, we found that. So if you have classical lesions where you have macrocyst and a single lesion, and or you have we get a lot of branch duct IPMNs on incidentally found by doing an US, and we have IPMNs which have classical appearance. So I think not all cystic lesions have a problem in inter-observer agreement. There are certain lesions in the cystic lesions. For example, if you have a serous cystic lesion which has macrocysts also. Now that's some because those varieties and those things can be there. And that's where, of course, the inter-observer variability will be there, and that I think the imaging also will be there.
So, right, so what you are trying to say is that for typical lesions it will be fine, but for atypical lesions we are probably having much difficulty there. So, but then that's what we want US to help us with. I mean, if
so
we have
I think the other thing to consider is probably the experience and how, if you're in a large volume center seeing pancreatic cystic lesions a lot, then I think the difference in inter-observer agreement really closes down. And I think you can't trust us when we say it's a serous cystic neoplasm. Sometimes, of course, at different centers, if they're different reports, there could be variability. Sometimes classical lesions are also reported otherwise. So I think the real role of US would be, of course, as somebody mentioned, to actually find the communication between the duct and also to get a cyst fluid analysis. So I think it's clear that these two are the basic indications. So if you're actually confused whether there's a duct communication or not, US can really help you. Appearance-wise, I think MR does a great job. Anyway, so appearance-wise, if morphologically, if somebody has to classify a cyst, I think radiology is quite enough. So, but if there are problems, then and the communication with the duct needs to be found out, then I think US can really help. And obviously, cyst fluid analysis is, I think, that's where we can help you out.
I guess that sums up the situation. So with this much data, Dr. Ramesh, what would you want to do with this patient? You want more workup or?
I think a cautious plan to do a short-term follow-up would be appropriate, because this is not, we haven't found anything really sinister so far. This is not to say that this lesion may not require some intervention later on, but at the moment, we would have to justify, we would only be able to justify an expectant approach. And if we have a high risk clinical suspicion, we can re-image after 3 months, but otherwise 6 months.
So how frequently we are going to image these patients?
No, it is only for the resolution. I mean, if you, for example, if you were to image this patient at 3 months and then you discover that there is a significant change in the morphology or characteristics of the lesion, which warrants even a repeat endoscopic ultrasound and repeat aspiration. If that happens, then it's simply taken off the surveillance chart. But if it shows pretty much the same, characteristics, and then you have to sort of, it's pulling back from red alert to, orange. So then you don't have to do images so frequently. You can do a 6-monthly imaging because you have already twice assessed the lesion and not find it to have worrisome features. Here, the only worrisome feature is the hypervascularity. If we think that is significant, then we have really, we should be doing a repeat FNA. I wonder whether the endoscopist who did the FNA used rapid on-site examination, or he or she, they waited for the report.
So we do routine rapid on-site, but even after multiple passes, there was not real material that could come out.
There
so just small drops of fluid.
There's one more criterion that I look at. What happens after you put the needle in? How much does the lesion subside? If it sort of subsides, the first problem, as you said, is how much fluid you get out of it. You got only a little. But what happened to the lesion itself after you stuck the needle in? Does it sort of subside completely, or did it remain pretty much the same size? That, I think, is also a significant factor in deciding where you want to go. Our own endoscopy colleague says, no, the lesion didn't subside, it's still there. And I think there's more to it than meets the eye. Maybe it requires surgery or something like that. So that's another observation that I have from my own endoscopy colleagues.
So if you have macrocysts, that's when you can really observe the shrinking of the cyst when you aspirate fluid. So you have like multiple, so many small cysts, which are really, really tiny and really this thing. So that's when you really can't appreciate the entire lesion actually coming down when you aspirate out of fluid. So if there are so many small multi-cysts and the amount of fluid that you aspirate, probably a single cyst may just shrink because they're all separated and they're loculated.
I'm sorry to interrupt, but I thought the lesions were 2 centimeters. The cysts were 2 centimeters in size in this case. A.
Yes.
And B, if it was really tiny microcysts, then we didn't do the FNA in the first place. Did we need to do that in the first place?
So we were only pushed to do the FNA because of the hypervascularity. So when we saw the lesion, we really thought an FNA may not really be helping us out because we may not really get the material that's required because there's small microcysts. And there was not even fluid that we could aspirate out of the cyst. But because of the hypervascularity, we just wanted to, find whether there will be some amount of material. We were pushed to do an FNA mainly because of
the
hypervascularity.
So I think observation is on the cards, and what we did advise was observation with the repeat MRI, contrast MRI at 3 months, and then we'll take it forward from there. So Dr. Ramesh, another question which I would want to ask you here, like you said, once at 3 months, and then we'll see how it goes. So would you follow the same protocol for a mucinous cyst we are going to observe, or there you do anything different?
If there is clarity in understanding that this is a mucinous cyst, then it's only in the cyst of 3 centimeters and less that limited follow-up is provided. Otherwise, the preference is for surgical resection.
So, I would have asked this question in the mucinous, but since you said 3 centimeter, but then, you still follow this 3 centimeters because some of the recent guidelines suggest 4 and 5. So,
yes, but the question is that if you look at all the published data, and don't look at guidelines. Guidelines have been made by a few groups of individuals. You notice that there is a sudden increase in the significance rate as you go beyond the 3 centimeter rule. It's not a magic number or anything like that, but by and large, three and more I tell myself to have a heightened approach to a more energetic management, not necessarily surgery. Even if you did follow up, it would be a very limited follow up. It would not be a sort of an endless process. The patient would be counseled that just to satisfy ourselves that we are not doing an unnecessary intervention, we are going to follow you up, but we're going ahead. And in fact, I looked up our data in preparation for this talk. For 94 consecutive cystic lesions, there was no patient in whom we had a negative, histology. In the sense, it was an unnecessary resection. It did not happen. So I think the formula worked reasonably pretty well. So that's what we'd stick with.
Soumil, what cutoff do you use for mucinesis?
Yeah, I think as far as branch duct IPMN is concerned, because I think the question of size really arises for a branch duct IPMN. The size should be 3 centimeters. And most of that is coming from the Fukuoka and the Sendai guidelines. I think the American guidelines have, and the Europeans have said about 4 centimeters as a cutoff. But essentially, it's so at the end of the day, I think it's one's individual clinical discretion in discussion with the patient, and the presence of other features along with the cyst size, like presence of mural nodules, pancreatic duct size, and enhancing features on the radiology. I think these will also contribute. But given that all of them are essentially favorable, cyst size of 3 centimeters and more should be kept under strict observation or even offered an operation.
And Dr. Nikhil, what cutoff do you use? Yeah, sorry, who's?
No.
Sorry.
Yeah.
Sorry to interrupt.
The
size was only mentioned as far as mucinous is concerned in the European guidelines only. As far as the other guidelines, they don't really mention any size. They say that if this is MCN, then probably if it is resectable lesion, patient is willing for surgery, then surgery is the way to go. But obviously that would mean sometimes unnecessary resections. That is right.
You would resect all MCNs?
If it is possible and it is resectable. So all the sizes are as such also arbitrary. There has not been any specific mention in the various data that I went through or the literature that I went through that specifically validated that, okay, this is the site that we would go and we would not go, except for the European guidelines where they have mentioned specifically than anything above 4 centimeters.
Okay.
So that way, our protocol will be, if it is resectable, we would resect it. Because otherwise we might miss some invasive malignancy. That is.
No, but the data says that if we are dealing with MCNs less than 3 centimeters, the chances of malignancies are to the tune of 1.9%. And comparing the morbidity of pancreatectomy along with mortality, I think we need to weigh the risk and benefits, right?
It depends upon what volume center you are working in. First. Second, the data also suggests that if you are going on an observation, then you tend to miss anywhere between 15 to 20% of malignancy also. So you have to weigh both those things simultaneously. So if it is a patient
what is your practice?
I usually follow a criteria of 3 to 4 centimeters. Actually, 3 or 4 doesn't make much of a difference. If my patient is asymptomatic, healthy, and it's a 3 centimeter lesion, preferably it's a distal pancreatectomy, I will straight away offer the surgery to the patient. More than 3 centimeters, less than 3 centimeters without any stigmata, I will follow all the patients.
If you're talking about data, I mean, I can quote a paper which I read recently, and it was like published in 2021, I guess. And so data of 424 patients with mucinous cystic neoplasm, out of which 10% were malignant. And I don't remember the whole paper, but it said that mural nodules CA 19.9 and size more than 5 centimeter, like predicted malignancy. And in the whole series, 10% were malignant. I mean, this paper suggested that 5 mm should be used as cutoff. And in the absence of these features, they said the incidence of malignancy is negligible. So I wouldn't say that we should use this criteria on the basis of one paper, but I think we can be a little more conservative than we are currently.
So Nikhil, the European guidelines actually have this thing that you're talking about with the MCN. And the International Association Pancreatology guidelines that we're talking about were published before the data came in. So one of the reviews said that the IAP guidelines were published in 2017, whereas the European guidelines came later on, included this paper which said that if it's greater than or equal to 4, then you consider resection, but less than 4, you can consider follow-up.
That is one single retrospective data analysis.
Yes.
So to base that on one single retrospective data analysis would be a little difficult approach. And that same paper also mentions that the missed malignancy is anywhere close to 1/3. In the same review that you're talking about.
So I think there is some disagreement there about the size, but I guess to sum it up, we can say less than 3 centimeters we can safely observe, right? And more than 3 centimeters, so somebody would use a cutoff of 3, somebody would use a cutoff of 4, and probably somebody would use a cutoff of 5. Fine. So, right. So once we are done with this, we'll talk about the next case. He's a 42-year-old gentleman who presented with pain abdomen, and ultrasound shows a cystic leader in the pancreatic body, and tumor markers were normal. So this patient underwent a CT scan first. So Dr. Ruchi, can you just describe this scan for us?
Yeah, so first of all, it's a gentleman. So that is an important thing to consider. Secondly, we can see a complex mass, which has both solid and cystic components in the pancreatic body, involving part of tail also, or pancreatic body only. And the solid component definitely shows heterogeneous enhancement. There is no calcification seen. The surrounding fat planes are maintained. Yeah, there are few thin septations in the mass. The remaining pancreas looks fine. I'll just try to see the duct. The duct is not dilated. So there are few small cystic spaces in the proximal pancreatic body.
What is your radiological diagnosis here?
So first of all, it's a malignant mass because of the heterogeneously enhancing solid areas. Now in the malignancy, the non-dilatation of duct goes against, the duct is not dilated, so it is against IPMN. Otherwise, that could have been one of the differentials. So first of all, the differential would be a cystic adenocarcinoma or cystic NET. I would like to see the arterial phase. Cystic
This was not a
tumor.
phasic CT, so this is the only contrast image we have of this patient.
Yeah. So the differentials would be cystic neuroendocrine tumor because it's a large, bulky mass. There is no apparent lymphadenopathy. And then cystic adenocarcinoma.
So if I use this opportunity,
SPEN is also a consideration.
So you can just briefly describe the radiological features of like these cystic neoplasms.
Right. So cystic neoplasm, first of all, we should see whether it's a unilocular or multilocular cystic neoplasm. In the unilocular category, the pseudocyst is the most common cystic lesion, which usually communicates with duct, which may or may not be seen on imaging. And in the pseudocyst, we can see septations, debris, hemorrhage, but there is no solid component. There may be some apparent thick component which may be attached to the rim, but they should not show any enhancement. Then in the unilocular variety, sometimes mucinous may present as a unilocular, but pseudocyst is the most common. Then in the multilocular, the serous cystic neoplasm, the mucinous cystic neoplasm, and the IPMN are 3 more common lesions. The serous cystic neoplasm have fewer cysts and more number of cysts and smaller cysts. More than 6 numbers and less than 2 centimeter size of the individual cyst. That is usually taken as a criteria. And it is present in 3 forms. The classical form in which there is a central scar and radiating septae, the honeycomb kind of pattern, which you showed in first case. And third is the oligocystic pattern, which may be confused with the mucinous cystic neoplasm. Then in the mucinous cystic neoplasm, it has high risk of malignancy. So it's a larger tumor mostly and found in middle-aged ladies. And because it has an ovarian stroma origin, so it has a very high incidence in female population compared to male population. In the mucinous cystic neoplasm, there are lesser number of cysts and larger cysts. And septations may be thick, there may be mural nodule, calcification. It also shows a communication with the duct. sorry, it should not show a communication with the duct, and it has enhancing components. And whenever there are enhancing components, there is a risk of malignancy. The size also matters. If the tumor is bigger, there are enhancing components, a lot of calcifications, then one should think about malignant transformation of the lesions. Then IPMN may be a main duct, side duct, or a mixed pattern. The main duct IPMN shows gross dilatation of the pancreatic duct. There are irregular walls which may show enhancement. The side branch is classically seen as a grape-like tumor in the uncinate process. That is a classical location. And the mixed pattern has a combination of side duct and main duct. So in this case, and then there is SPEN, which is a special category, which is mostly solid tumor, but with cystic degeneration, as Dr. Ramesh nicely demonstrated in his talk. So SPEN shows a lot of enhancement, and usually the tumor is big at presentation because the patients are usually asymptomatic with SPEN unless the tumor grows very large. There may be hemorrhage, calcifications, necrosis in SPEN. Then there are cystic transformations of malignant tumors like adenocarcinoma, neuroendocrine tumor with cystic transformation. So in all these, there will be heterogeneous enhancing component with cystic or necrotic component. So in this case, we are seeing a complex solid cystic mass. It's not exactly a cystic tumor. It's a complex solid cystic mass with a lot of enhancing component. It's a man. So there is a very little possibility of a mucinous adenocarcinoma. There are higher possibility of either a cystic variety of neoplasm or a cystic variety of adenocarcinoma NET or a SPE. So that is my differential diagnosis.
Thank you, Dr. Ruchi. So, Dr. Soumil, with this imaging, are you happy to take up this patient for surgery, or do you want to do further workup?
No, I think there is enough data here to proceed and offer an operation, a resection to this patient. Simply because he's symptomatic, number one. The number two, he's got a cyst of 5.6 centimeters in its largest dimension. There is solid component there, and there is septation and there is enhancement. So based on his symptoms, based on the size, and based on the radiological features, there is enough evidence to suggest that this is likely to be a cystic neoplasm, possibly malignant unless proven otherwise. And doing a further investigation of doing further EUS with sampling is not going to essentially change the course of treatment. So he should be offered a resection with a regional lymphadenectomy. And the chance of this coming back as a benign, or basically what we are looking at is a pseudocyst, is very, very small. So there is enough evidence here to proceed with an operation.
So, Dr. Nikhil, would you want to do any?
Yes, I'll have a detailed discussion with my radiologist. Like, suppose my radiologist is saying that neuroendocrine differentiation is one of the differentials in my lesion. So for me, I would prefer an EUS FNAC. Plus, I would require some markers, because if it's a neuroendocrine tumor, and then I would like to further evaluate it by getting an axial imaging in the form of a Dotanox scan if it's a grade 1 or a grade 2 tumor. If it's an adenocarcinoma, definitely I would like to have a PET scan done, because the chances of malignancy, as I'm expecting, very high. So it might change my management if I get some metastasis in liver and some other part of the body. So definitely I would require.
I mean, the only other thing I would do here is an HRCT of the chest before proceeding with a operation. I mean, you could do a chromogranin and an HRCT chest. If there is no evidence of any nodules in the chest, etc., then regardless of whether it's a neuroendocrine tumor, I mean, you've done a CT scan already, which shows that there is no spread within the abdomen. And if there are no nodules or anything else on the chest, then I think regardless of whether we are dealing with an adenocarcinoma or a neuroendocrine tumor, the treatment won't change. Of course, one can do a DOTA scan or any other cross-sectional imaging as a matter to complete the algorithm and complete the investigation chart. But in terms of decision making, I don't think that would essentially alter the
My decision making would definitely change if it's an adenocarcinoma and I get any lesion in the liver or something, which might be missed by CT scan, because I don't have a triple.
Do you do a CT scan for CA pancreas? I mean, sorry, after a CT scan or PET scan, do you do routinely for CA pancreas?
For an adenocarcinoma, I always do it. Yes, I'm following it. Obviously, I don't have any, unfortunately, we don't have any data. Many a times we have found patients were having supraclavicular small lymph nodes or mediastinal lymphadenopathy on PET scan. Obviously, HRCT scan would also find out, but I don't have a data, but definitely changes my management in reasonable number of my patients.
And Dr. Saurabh, what do you do?
I would also concur with Dr. Soumil. This patient I would actually offer in resection. I won't be inclined to do any further evaluation per se, at least with the imaging that we have got. So my concurrence also with Dr. Soumil.
So, like we also went ahead with surgery. This patient was resected.
Nikhil,
Yeah.
I want to ask the plan of doing a PET for every suspected pancreatic malignancy. Would it be followed by an FNAC proof? Because just if cervical lymph node yields a high SUV value or SUV max, does it is synonymous with metastasis, or would the
Not necessarily considering the Indian setting, but if I'm dealing with adenocarcinoma, many a times we have found patients who have got
no? My question is, would you biopsy that lesion?
Yes,
and
definitely, sir. Before
confirm
ruling
it?
them out, definitely, yes. Before
Yeah.
ruling them out, they are metastatic. I would like to rule out metastasis first.
Yeah, I agree that the current scenario, it is not, recommended. But if the economics and the logistics are okay, and if the investigator is willing to do biopsies and prove it, it is a perfectly acceptable proposition. It is especially acceptable if the patient were high risk for surgery, and then you could, of course, be that much more careful in removing those with potentially less benefit. But in a philosophical manner, on the other side, if the patient were not high risk for surgery, would you give them the maximum, do the greatest good for the greatest number, or would you like to sort of whittle it down all the way down to the minimum number? It's just a philosophical question, that's all. But I guess it's up to everyone to do what they think is just a comment, that's all.
Yes. So I guess we did operate this patient, and there was a 5.5 centimeter lesion in the body of pancreas. It was infiltrating transverse mesocolon, and he underwent a laparoscopic distal pancreatic splenectomy. So maybe I can ask a surgical question here. Dr. Nikhil can take it. So which patients you would do a spleen preserving pancreatectomy?
Spleen preserving, considering this size of a lesion, I think spleen preserving would not be one of the option for me. However, smaller lesions, grade 1 neuroendocrine tumors, SPN, I think, which we don't have any, or any MCN, in which we don't find any malignant potential, but the size is more than, they don't have any invasive malignancy or a high-grade dysplasia on FNAC, but the size is more than centimeters, which are demanding surgery. In these patients, I think we can go ahead with spleen preserving pancreatic.
Do you use any size cutoff?
No size cutoff. Only MCNs, as far as I always follow size as one of the major criteria for performing surgeries on MCNs, right? So if I've got an MCN size of more than
cutoff for doing spleen preserving.
splenectomy, no, size doesn't take precedence over my decision making whether I have to do a splenectomy or not.
So you would like, if you can preserve in an MCN or a smaller NET and SPEN, you would tend to preserve spleen.
Preserve spleen, definitely. Yes.
Right. I guess most of us do that. Any disagreement? So this turned out to be a grade 1 NET, and like after that he's on follow-up. If we would have known probably this before, maybe we would have done a DOTA scan, but it's okay to operate. So I think that sums up mostly about MCN and serous neoplasm. And let's just do a brief case of branch duct IPMN, and then we'll close this. We are 8:15. So a lady, 66-year-old lady, presented with clinical features of acute cholecystitis. Ultrasound showed acute cholecystitis, and there was something in the pancreatic head. They said pancreatitis, and LFT had mildly elevated bilirubin, and CA 19.9 was 141. She underwent a CT scan. CT scan didn't show much. It was suggestive of acute cholecystitis. Then CBD was mildly dilated and she underwent an MRI. It was MRCP actually, and the MRCP, apart from acute cholecystitis and mildly dilated CBD, showed a well-defined cystic lesion along the posterior margin of pancreatic head, and it was abutting the terminal CBD, and there was no the accessory pancreatic duct was coursing along the lesion, but not inside it, along its inferior aspect. So this is the MRCP image. I'll show you some more images, but Dr. Soumil, what next?
So at this point, I would offer her. I mean, was the amylase raised in the first instance? You must have.
No, she didn't
No,
have pancreatitis.
They didn't have pancreatitis. Yeah, I would offer her an EUS in the first instance to look for any biliary ductal calculi, number one. And number two is, given the fact that she had a little elevated bilirubin and you seeing a cystic lesion, which could potentially be a neoplasm in the head of the pancreas. So I would like to do an EUS with sampling of that pancreatic cyst before we could proceed and offer her a treatment for her cholecystitis.
Now, can you see this DICOM images?
Yeah.
Yes.
So, Dr. Ruchi, can you just, I mean, the first one is the CT scan. CT scan is not very contributory here, but you can see this list of the images and just describe it briefly.
Yeah, on these images, I can see a well-defined cystic lesion which appears unilocular on the coronal T2-weighted image, on the axial also. And it's in very close proximity with the pancreatic duct and the CBD. The CBD is seen above the lesion, but the lesion is not causing any compression. There is no solid component seen, and it's a clear fluid. There's no debris or hemorrhage. The pancreatic duct, I'm not able to see on these images.
So what's your DDs here?
So if this is just a unilocular cyst in the uncinate process of pancreas, then it may be just an incidental simple cyst also. Had I seen a communication with the pancreatic duct, I would have been more cautious in labeling it as simple cyst. Communicating cyst could have been a IPMN or a pseudocyst. But right now, I can just see a well-defined simple cyst in the uncinate process. In the MRCP images also, I can't see any communication.
So obviously with the clinical feature, as Dr. Soumil suggested, that we would still go with an endoscopic ultrasound, and endoscopic ultrasound suggested obviously cholelithiasis. There was CBD was mildly dilated. There was no stone there. Mild sludge was there, and they said that there is a mural nodule. Nikhil, what next?
Actually, I'm very confused right from the beginning. I don't know whether this patient, if comes to me in the OPD, I would go send the patient for endoscopic ultrasound. Considering the clinical setting of an acute cholecystitis in a patient having a mildly dilated CBD, and I was expecting there should have been a pars stone. This cyst per se would have been an incidental finding. This is what I thought, considering the MR report as well as the CT report. But fortunately, the patient didn't come to me, and the endoscopic ultrasound showed a mural nodule. So considering this lesion, I think definitely we would require our US guys to, they should have FNA'd it. But a 20 into 15 mm cystic lesion in the head of the pancreas with a mural nodule, it is a sinistral sign. So I think we should offer a surgical intervention in this patient.
Why wouldn't you, like, see, there is no raised amylase lipase. They were done in the initial setting, and there are no signs of pancreatitis on the imaging.
Is, very subjective. Many a times we don't find patients with pancreatitis who come to us. They have raised amylase lipase, right? So considering this, the whole setup of the patient was suggestive of an acute cholecystitis with the passage of a CBD stone, right? This is what my first
Not
differential.
really. I mean, acute cholecystitis, right? But there is nothing to suggest that the CBD stone has passed.
Okay, if a patient who comes with an incidental unilocular small cyst about 1.5 into 1 centimeter, after MRI, I think endoscopic ultrasound is only required as per the guidelines if there is some signs which are suggestive of sinistral signs like mural nodule or an enhancement or a PD dilatation, then only we should go for an EUS. This is what my
But raised bilirubin, how do you explain that?
CBD passage of CBD stone was my first differential. Definitely yes.
If there was no
Obviously,
pancreatitis, raised OTPT was not there.
The LFT is a plumb normal.
The
in
only
this
feature, I agree. I mean, this case I borrowed from somewhere, but initially I thought that I was probably, endoscopic ultrasound was justified or not. But with a raised bilirubin, I think it can be justified. Dr. Ramesh, would you want to comment here?
Well, what was the size of the mural nodule? Is there any information?
They haven't mentioned that.
If there is dilatation of the bile duct with jaundice, I think we have to increase our sense of apprehension. And so in the US would be appropriate. Needling it would also have been appropriate once you do it in the US. In fact, it's without a needle, the US is kind of very, sort of.
Not needed, sir. I mean, I was coming to that.
Yes. So I would have aspirated it and then followed the findings of the aspiration as well.
Yes. So these are the findings, like amylase was high, glucose was very low, and CA was borderline elevated. And the cytology impression was mucinous cyst.
Could it be a branch duct IPMN as well? Because the amylase can be raised. It's not in the main pancreatic duct after all, because there's no dilatation of the main pancreatic duct.
Yes. So I guess now the DD most likely will be limited to branch duct IPMN. So Dr. Soumil, would you operate this patient now?
Yeah, so I think strictly going by the guidelines, even a branch duct IPMN, if it is causing jaundice, needs surgical intervention. In this situation, the bilirubin is marginally elevated, it's 2. So maybe I would repeat the bilirubin after a couple of days, maybe after 2 weeks.
This patient actually underwent ERCP following this. So
okay, right. So
the opportunity is lost.
All right. So if the ERCP and presumably an endobiliary prosthesis was inserted at a ERCP, so well, I would follow this patient up, discuss it with the patient. Ideally speaking, yes, it's a branch duct IPMN with jaundice. It requires a resection because one of the indications in branch duct IPMN is presence of jaundice. But given that the bilirubin was only 2 marginally elevated, there is a small case for keeping it under surveillance. I would discuss it with the patient. If the patient wanted to have this kept under surveillance, maybe I would re-image her in about 2 or 3 months time, but definitely not miss out on the gallbladder. If do a laparoscopic cholecystectomy and keep her under observation after due discussion, if they are unwilling to have a upfront resection in form of a Whipple.
Sawan, you want to add something? Actually, the scan.
I think a mural nodule, I think, is the sinister feature here.
Yes.
And generally, the amount of cytology report that's there. So generally, it's always mentioned that from the cyst fluid, the cytology that's done generally doesn't give so much of information. So I'm thinking they must have needled the mural nodule. So if the mural nodule is showing atypical cells, then I think it's something which we should be concerned about.
Nikhil,
you wanted to add
can I ask a question, Nikhil?
Sir, please.
I would like to ask Ruchi and the others, what is the criterion on which an MRI report of microcalculi is given?
Sir, microcalculi are very difficult to see on MRI. In fact, I was thinking that the raised bilirubin in this case could be because the sludge was reported in CBD. And
my question was because there was some report of microcalculi, and I see it many more times. I've seen it in my practice, and each time I'm a little confused because I don't really understand what it means.
It's 2 millimeters or less than that.
Okay.
Yes.
And considering that in the gallbladder, sludge and stones can all be compacted, and so size per se, it's a brave person who puts all their money on the size of the intra cholecystic lesions. So I don't know. I would not.
No, when they are microcalculi, then it's not clustered gallbladder. Usually they are floating in the lumen.
Okay.
Saurabh, you wanted to say something?
No, I'm also of the opinion that probably it can be observed. This patient can still be observed, and we can follow up this patient. There are a couple of things only that one Dr. Sawan mentioned is the mural nodule, although we don't know what is the size of the mural nodule. That is one. And second, the symptomatology of jaundice. And usually, if we follow the guidelines, then jaundice would be an indication for dissection for a patient who has a cystic neoplasm, especially if we are considering the most.
Yes. So I guess both options were there, but I mean, there were two sinister things, and I think that would have required a discussion with patient, and this patient did undergo a Whipple finally, and this was the biopsy. So it was a branch duct IPMN with low-grade dysplasia. So she could have actually been safely observed, but then we are always wiser in retrospect. Right. So I think with this, our panel discussion concludes. If there are any comments or any questions, we would want to take that. We have a couple of questions on the chat box, and Anand Narayan Singh has asked Dr. Sawan, how many atypical lesions FNAC will be helpful in your practice?
So exact percentage would be very difficult to say, but if they're really atypical, then I think the only option is to move forward with an FNAC. And sometimes raised amylase levels help us differentiate, and CEA does differentiate. I would say anywhere with half of the atypical lesions or less than half, we would be able to differentiate with an FNA. The confusion would still remain after the FNA.
I can see you. Anand? No. And Azaz Wani has asked what MCNs do we don't resect. So I think we did discuss that in the panel discussion, that we don't resect smaller MCNs. And there's one question which Gagandeep Singh has asked, which is not relevant to this, but he's asking small periampullary tumor, and if he has cirrhosis and ascites. I mean, obviously the question surgery is out of question with ascites. Dr. Ramesh is smiling. Sir, do you want to add something?
No. I think he just wants to ask the question because I think once there is decompensation, straight away it takes the patient out of another attempted curative therapy. Of course, if ascites is due to some nutritional reasons, and then you can sort of rally the patient around, and if the portal hypertension is not severe, then you may at a future date even consider some form of an endoscopic or surgical ampulectomy, even for that matter.
I just use this opportunity. So which cirrhotic patient you do a Whipple?
I think the two things is, one is the synthetic function is good, and second, the portal hypertension is not very severe. So if these two are met, then it's all right. And if the tumor, of course, must be eminently resectable, and there should be no borderline resectability considerations. There should be no doubt about metastasis. And these are the patients that would go the whole hog to evaluate for distant metastasis and for every other possible confounding factor which would affect the outcomes of resection. So in the straightforward patient with the low risk, I would tend to give the benefit of resection, to a larger number. Conscious as I am that some of them may show up with early metastasis.
And how do you manage post-operative ascites? I mean, that's a big problem.
Post-operative ascites is it happens for a multitude of reasons. And if it's just as part of a dilutional hyponatremia and just a serositis, it sort of settles by itself. We take out the drains, and we don't sort of keep the drains forever.
For how long? I mean, because problem with taking out the drain is that they will accumulate. So either we do a routine tap, or otherwise the abdominal will bloat, and our suture, I mean, the abdominal closure is at risk. So when do you take it out? And
I think day 7 is a reasonable cutoff when your abdominal wall is kind of healed and you don't have the possibility of ascitic leak through the main wound, which is the biggest disaster you can get. So once that is fairly okay, then we do add diuretics to for these patients. And if diuretics work, that's fine. Then we quickly take off the drains. If they don't, we remove the drains and place a colo bag and allow the extra ascitic fluid to drain through the openings of the left by the drain. And that usually drains for a few days. And then by the time...
use a cutoff of drainage like 500, 1 liter, or any drain output you will?
I think if it's low amylase and if it is culture negative. If it is culture positive, then we are a little more concerned. In culture positive patients, I would be, certainly very slow to remove drains. I'd leave them in a colo bag for even weeks because I'm concerned that the infected material will collect in the abdomen and the patient would, and as has happened in our experience, they suddenly, collapse in the ward with septic shock. That would not be something that I would desire. But if the fluid is sterile and if it's serous and does not have chyle or bile or pancreatic fluid, then it's perfectly acceptable to be
You remove the drain even with a 1.
I'm sorry?
Would you remove the drains even with 1 or 1.5 liter output per day I'm talking about?
Probably not, but we would have stepped up the diuretic by that time and brought it down to certainly under 500, although it's not a magic figure or anything like that. But as you step up the diuretics and the patient is completely on enteral feed, either oral or jejunal, it's pretty much, there's no sepsis. If the overall picture is good, then the drains alone are not going to be a problem. If the drains are part of a festering sepsis and the patient is not thriving, then obviously...
I'm asking in the context of cirrhosis, sir.
Oh, in the context of cirrhosis, I would take off the drains early, definitely. And then I would take off the drains very early. And then I would place trilumen catheters, which, there's one catheter, the one we use for central lines, and I just place it in under ultrasound guidance so that it won't puncture a vessel, and keep it clamped and release it whenever I feel that the ascitic fluid is more.
Which catheter, sorry?
No, just you can use any central venous catheter assembly. Which has more than one lumen, which allows you to, even if one lumen gets blocked, then the other one is open, and it's got a narrow gauge, so you don't drain all the ascitic fluid in one go. So we just sort of clamp it, allow say 500 or 1000 cc to drain today with albumin replacement, and then go on, and we may do it again tomorrow. On day 3, the catheter has to come out because we are very afraid of infection. So we just take out that catheter, then we put another catheter 2 or 3 days later in another flank, depending on the ultrasound findings. So no large bore drains, and we don't want leak, and we don't want a management mess.
So I'm actually struggling with a cirrhotic Whipple.
Yeah.
Just wanted an input there.
Wish you all
thank
the
you
best.
very much. And thank you, panelists. Thank you, Dr. Soumil, Dr. Nikhil, Dr. Ruchi, Dr. Sawan, and Dr. Saurabh. Thank you for such a informative session. And next, we are discussing retroperitoneal sarcomas. Thank you. Good night.
Thank you.
Thank you very much. Good night.
Thank you, sir.
Thank you.